see. It goes
Okay.
like this. noise, but hey. Isn't this a great facility? I'm excited to be here. I would ask everybody to come a few rows closer, but I know you all like your comfort, so you're welcome to sit where you're comfortable. And I know a few more folks are going to be coming, but we're going to get going, and they will have to watch our YouTube video. We are videotaping this, so when we get to the point of having Q&A, we're going to ask you to use a microphone to make sure everything comes through loud and clear. So good afternoon. Okay, we're ready to go. Anyway, I'm with CTAC, and I'll be the moderator. CTAC, along with the American Heart Association, are very happy to co-sponsor this session. It's going to be, and it's exciting to be able to talk about moving research into policy to really improve support for caregivers in this nation. A word about CTAC. CTAC is made up of more than 140 organizations. We share a common interest in bringing about better care for people with serious and advanced illness. We represent a broad range of stakeholders, from healthcare providers, that would be physicians, nurses, social workers, home care workers, to consumers, faith groups, patient advocates, health plans, foundations, employers, and innovators. Just about everybody who has a stake in this issue. We know that people who have a condition that they're not likely to recover from often receive poor care, no care, or care that they don't want. As Dr. Atul Gawande, the author of the best-selling book, Being Mortal, which I know most of you have probably read, said, "The ultimate goal is not a good death, but a good life to the very end." And that's what we're aiming for. Our members, including today's co-sponsor, the American Heart Association, and my former employer, AARP, know that caregivers, especially family caregivers, are key to ensuring that the seriously ill person is able to live the best quality of their life according to their own wishes. That's why we're excited to be working with the Federal Patient-Centered Outcomes Research Institute, or PCORI, to promote the results of several of their funded studies which are providing actionable information, news you can use, to enable you as an implementer to bring about changes to improve caregiver satisfaction and patient outcomes. Our program today is being videotaped, and so we're going to provide you information on how to watch it later. Before we introduce our panel, I'd like to first ask my co-host, Dr. Eduardo Sanchez, Chief Medical Officer for Prevention for the American Heart Association, to give some opening remarks. Dr. Sanchez has had an illustrious career. I'm going to give him an introduction here. In public... Okay. So let me tell you a little about Dr. Sanchez, okay? He's had an illustrious career in the public and private sectors, notably also serving as Chief Medical Officer for Blue Cross Blue Shield of Texas, as the Texas State Health Commissioner, and chairing many state and national public health commissions. He's received numerous awards and recognitions and has earned both an MD and an MPH from the University of Texas. And here's the ringer. Dr. Sanchez has a master's and an undergraduate degree in biomedical engineering, and he's going to tell us what that is. Dr. Sanchez.
Thank you. Thank you so much. Thank you so much. I won't spend time telling you about what biomedical engineering is, although every single day people in clinical care benefit from the work that biomedical engineers do. Thank you so much for that very nice introduction. I am so pleased to be here, and on behalf of the American Heart Association and our leadership, I welcome you and welcome those of you who are listening today and will be listening in the future to this really important discussion. The American Heart Association is an organization that believes that science is the foundation of all that we should be doing. So it's really great that we are engaged in a conversation that is going to attempt to capture the collective experience of many at the end of a good life and turn it into ways that we can make that end of a good life even better for many, many more people. I love that a good life to the very end, because the American Heart Association has a new mission statement, and I'm not a mission statement guy. I couldn't have told you the Blue Cross Blue Shield of Texas mission statement, or the, I did know the, I sort of needed to know as the commissioner, the mission statement of the Texas Department of State Health Services. But our mission statement is to be a relentless force for a world of longer, healthier lives. And if you think about it, what we're doing here, and I think we are so pleased to be a part of this, longer, healthier lives includes and must include a good life to the very end. I also want to share with you that first and foremost, or in addition to all the things that I have titles for or participation in, I'm a husband, I'm a dad, and I'm the son of two great parents, one of whom died of heart failure the day before Thanksgiving 2015. And the experience that I, my siblings, and my mother had as it related to that getting to the very end, I'd be lying to you if I characterized it as a good life to the very end. And the experience that we as a family had, a family with not one, but two physicians, a forensic psychologist, a mother who's been the chief health officer for her family for as long as she's been married to my dad, the challenge of knowing what to do or knowing what to think about or preparing for what might be coming was not so obvious as it could have been. And in my own medical training, particularly in pediatrics, one of the principles of pediatric care is anticipatory guidance, helping parents know what it is that's going to happen over the next 3 to 6 months or the next year. And we really need to adopt an anticipatory guidance approach to what the end of a good life ought to look like. And so I am so very pleased that we are here to talk about the science that can inform that, so that rather than think that you're doing the right thing and maybe not, or think you're not doing the right thing and maybe so, we actually have some science that can guide how we go about making that very end be as good as it could possibly be for all involved. That was the anecdote part. And anecdote, I learned as commissioner. I've learned as commissioner, and I've learned working for AHA, and I've learned in work that we do with employers. Stories and storytelling are critically important. But again, we're a science-based organization, so I just want to share some statistics with you, because I think that we at AHA are ready to be a part of this conversation. I think too often when people think about palliative care, end-of-life care, and for those who can't see, I'm doing air quotes, we think oncology, but there are some other areas that ought to be part of the discussion that's being had, and also part of how we inform those care teams about what things they need to be thinking about. Pain management may not be so prominent in some of the other areas. But just some quick statistics for you, and I'm going to focus on heart failure and then we'll get going. In 2016, there were approximately 79,000 deaths due to heart failure. That's, to put some things in context, about 675,000 deaths are attributed to cardiovascular disease annually, about 600,000 deaths attributed to cancer annually, and about 140,000 deaths attributed to stroke. Diabetes, which is number 7 on the list of the leading causes of death, about 83,000 deaths in 2017. So heart failure, if it was by itself, would come in at number 8, and that's pretty significant. But the thing about heart failure is that, like other things, it spells maybe an accelerated path to that end, and making it as good as possible is critically important. The 5-year case fatality rate after hospitalization for heart failure is 40%, at least according to one study. That means 2 out of 5 persons may not live beyond 5 years, which means that there is good reason to have some anticipatory guidance conversations with families where, at the very least, heart failure hospitalization may and might ought to be a point at which a conversation is had. I'll go back to my dad. My dad was hospitalized maybe 6 to 7 times in the course of about 2 years, and never, ever in the healthcare setting, whether it was ambulatory care or in the hospital care setting, did anyone say, y'all, that would be my mother and my dad, y'all might want to think about a few things as things evolve, and figure out a healthy, safe, non-judgmental and non-threatening way to engage in that conversation. And I do think that there is a legitimate role for the healthcare system to be playing, and I think that some of what we're going to hear today is about some lessons learned by way of research, and some ways of taking that research and turning it into action and or policy. I think I'm going to say 2 more things. The past couple of days, interestingly, there's been this convergence, at least in terms of the things that I've been involved with, that have to do with thinking about the patient first, and some patient-centric issues. Yesterday, I drove back from Austin, Texas, where I participated in a conference on oral health. That's not the connection, although it probably could be. I certainly made the case that oral health is connected to so many things. But I was at a meeting last night of our training for our valvular disease, heart failure, and stroke ambassadors. Those are individuals who have suffered an event or are related to somebody who suffered an event, and on behalf of the American Heart Association, tell stories about these things that we can then back up with some science and talk about some opportunities to change the trajectory of people's lives who might have been diagnosed with one thing or another. And then just this morning, I co-chaired a call. I'm the co-chair of a planning committee on the Science of Patient Engagement Summit that's coming up in October. Again, how do we apply the lessons of scientific inquiry to help us understand how to do a better job of patient-centeredness and patient engagement, and bring it all full circle here to figuring out how we help everyone have a good life to the very end. So again, on behalf of the American Heart Association, I say thank you very much for being here. Thank you for being interested. I'm looking forward to hearing about the science, but more importantly, I'm looking forward to what comes after the presentation of the science in the months and years to come, where we can take lessons learned and apply them to policy and apply them to action. So again, thank you.
Thank you. So now I'm going to introduce our 3 panelists, and I'll ask them to come and take their seats up here. They're each going to give a brief presentation of their work, and then we're going to have an opportunity, after they've each spoken, I'm going to ask them a couple questions, and then I'm going to ask them to ask each other questions, and then open it up to you in the audience. So if you want to think about the questions you'd like to ask, maybe scribble them down. As I said before, when we ask questions, we're going to ask you to talk into the microphone for our televised audience. All right, so Supriya Gupta Mohil, MD. She's a board-certified geriatrician and oncologist and has developed a clinical and research program in geriatric oncology by strengthening the links between the two disciplines. She has had residency and fellowships at the University of Chicago Medical Center, where she also earned a master's degree in health outcomes research. Her research interests include the evaluation of patterns of care, health outcomes, and quality of life related to treatment for cancer in older patients. Her research has been funded by Hartford, by the National Institute on Aging, by PCORI, and by the National Cancer Institute. She's an integral member of the University of Rochester Community Oncology Research Program. She leads the cancer care delivery research efforts in that program. She's the editor-in-chief of the Journal of Geriatric Oncology, and she spends her copious spare time mentoring the rising stars in the field. So Dr. Mohil will discuss her study on improving communication for chemotherapy, addressing the concerns of older patients and caregivers.
Thank you.
I'm going to go through everybody
Okay,
first,
great.
and then Dr. Jing Li is an associate professor in the Department of Internal Medicine at the University of Kentucky. She's also co-director of the Center for Health Services Research there. She has an extensive experience developing interdisciplinary teams, establishing community coalitions, and improved care coordination and patient safety, enhanced in-setting and cross-setting teamwork, and documented improved patient outcomes. She worked at the Alabama Quality Improvement Organization, the QIO. There she focused on improving healthcare through process improvement and performance measurement and health information technology. She's received funding from the NIH, from PCORI, and from CMS. And she is going to talk today about her Project Achieve, identifying which transitional care services matter the most to patients and caregivers. And then we are going to wrap up with John Schall, who is the Chief Executive Officer of the Caregiver Action Network. He is recognized nationally as a thought leader on caregiving issues and trends, and he links private sector goals with healthcare public policy. I think we're hearing that about a number of our speakers, that they both work in the private sector and in the public sector. In addition to working both in the private and public sector, Mr. Schall has served once upon a time as Senator Bob Dole's chief budget advisor in the Senate Majority Leader's office. He was a guest scholar at the Brookings Institution. He was almost a member of Congress, and having narrowly lost his bid. And he also served as chief of staff in the Department of Labor, was a White House domestic policy advisor to President George H.W. Bush, and deputy of the White House Policy Council. He earned a Master of Public Policy degree from Harvard University's Kennedy School of Government, and a BA with distinction and honors in political science from the University of Michigan. Mr. Schall is going to discuss the results of the Cancer Action Network program on training family caregivers in team-based decisions. So we will start with Dr. Mohil.
It's a pleasure to be here. Thank you very much. In my spare time, I also have 2 children and a husband that take care of, that I have to deal with at home. But it's really lovely to be here. And I think I just, we had some slides here. So it's lovely to be here, and it's a privilege to be able to talk about our study that was funded by PCORI to really look at how to improve communication between older adults with cancer and their caregivers. And I'll report briefly those results to inspire our conversation today. So we know that aging is happening. Currently, about 12% of patients are age 65 and over, and this will increase to almost 25% by the year 2040. And older adults who are more disabled at home have increased caregiving needs, and many of our caregivers who take care of older adults are also older themselves and have their own healthcare needs. And so this was a article written by Paula Spann, who does a lot of great writing about geriatrics and older adults, revealing that, it's more and more difficult as with the aging of the population and where patients are going to be living on caregivers. We know that because of aging, cancer prevalence and incidence will be higher in older adults. In fact, 60% of cancers are in older adults and 70% of deaths from cancer in older adults. And unfortunately, people in the oncology world, practitioners are not always well trained in aging. And so what we see there's all these aging-related concerns that older adults have that are not really addressed in the oncology side. And here's an example from an audio-recorded visit that we use in our research between a caregiver, oncologist, and a patient. The caregiver says about the patient, well, she's been spending a lot of time in bed lately, and for some reason she's not able to stand. And the oncologist says, I see. And the caregiver says she doesn't walk long distances, that's why she's in a wheelchair. And the patient says, I want to go dancing, I want to get out of this wheelchair. The oncologist says, well, I think we can get you feeling better. How about Norco, which is a pain medicine? And so here's an opportunity to discuss what's going on with the patient's functional status, what's going on at home, and the caregiver needs. Caregivers don't go to their doctors for the patient and say, I'm distressed, I need help. They say, I'm taking care of my loved one's not doing well, I need help. And it comes through like this. People don't overtly say that they're distressed, and you have to read between the lines. So there's a lot of missed opportunities for communication. In geriatrics, we have a toolbox called the Geriatric Assessment, which allows us to capture information on health status that is important to older adults. And these health status domains include function, cognition, physical performance, comorbidity, nutrition. We know all of these domains are important and impact outcomes. But only 20% of oncologists use these tools because they're not really trained in aging. And so our goals were really to see if these tools can influence communication. Here's an example of a tool of operationalizing cognition and giving doctors a checklist about cognition. Did you ask about cognition? Did you elicit the caregiver's perspective about cognition of the patient? Did you think about decision-making capacity? These are all important constructs when we're thinking about cancer treatment, but again, oncologists who are not trained in aging don't ask about cognition, yet are giving really difficult treatments like chemotherapy or putting people through difficult surgeries. So the aims of our study were to look at patient outcomes, satisfaction with communication, and to see if giving a geriatric assessment can increase the numbers of conversations about aging-related concerns. I'm going to focus mainly on our caregiver outcomes because that's the topic for today. Here was the design of our study. It was a cluster randomized study of practices across the country. And the practices that were randomized to the intervention, the doctors got a summary of the geriatric assessment along with the checklist like the one I showed for each of the geriatric assessment domains. And the other sites, the practices were usual care. We looked at communication. We audio recorded all the clinic visits. And we looked at satisfaction and quality of life. We were able to enroll 541 patients, so these are patients age 70 and older who have a geriatric assessment problem and advanced cancer. 414 caregivers and over 300 physicians at 31 sites. And we presented our primary results at our national oncology meeting that showed that the number of conversations increased. When oncologists got a geriatric assessment summary, those conversations were higher quality and led to more recommendations that could impact outcomes. Things like physical therapy for falling, things like mental health care for older patients who are depressed. What was striking was the prevalence of problems in the older patients. Now again, patients are seeing their cancer doctors, and cancer doctors aren't asking about these problems. And we see that there's a high prevalence when we look on geriatric assessment of things like physical performance problems, polypharmacy, comorbidity, functional problems. So the problems are there. And what's happening now with the geriatric assessment when we use it is that the oncologist can address these issues and talk about them and do something about them. We also know that caregivers are distressed. So 44% of the caregivers in this study were reported distress. They had comorbidities. 24% were anxious, and 20%, almost 20%, had depression. And the number of problems on the geriatric assessment, on the patient geriatric assessment, increased the risk of having those problems. So the sicker the patient was, the more emotional distress the caregiver had, showing how patient health and caregiver health are interrelated. In terms of caregiver satisfaction, providing a geriatric assessment improved caregiver satisfaction when they talked about the patient's issues. So when patients have problems, the caregiver's worried about them too, and the geriatric assessment allowed caregivers to express their concerns, and they were more satisfied with their clinical care. It did not improve caregiver outcomes such as quality of life and emotional distress. We did the geriatric assessment once, and my hypothesis is that we need to do it over time to see more longer-term outcomes on quality of life. We did have stakeholders that worked with us on our study, and the stakeholders learned quite a bit. We learned quite a bit from the stakeholders, and they learned from us, and here's some quotes from them. Stakeholders who said that they really thought investigators didn't really listen to them, but in our study, being involved showed that they really partnered with us in a productive way, and that this sort of communication was authentic amongst the stakeholders and the researchers. So I want to thank everyone that participated in this study. I want to thank CTAC for inviting me here today, and PCORI and the NCI. And one of our investigators, I always end with these now, Arthi Huria, is a leader in geriatric oncology at City of Hope. She unfortunately passed away in a car accident last week, so I honor her at most of my talk, not last week, in November of last year. So I honor her with, by ending with one of her quotes. She was an investigator on this study, and compassion and active listening is the core of what we should be doing in clinical care. Thank you.
I think you're next.
I thought you were going to have a question asked.
Oh, well, or here, why don't we do that? All right. So, since the presentations are not directly related, we thought we'd start with a few questions here. So if anybody has them, I'm going to ask a question,
Sure.
which is, do you find that oncologists are adopting this intervention for patients and caregivers? And if not, to what extent are they doing it, and what are barriers to that?
Yeah, so when we asked oncologists at the beginning of the study, only 20% were doing any kinds of tools like this. I helped write a guideline from our National Oncology Organization that advocates for these tools to be used, but oncologists are still not using them. They feel like it's too burdensome. They're willing to do CAT scans, biopsies, put people in the hospital, and all of these other things. But this patient-reported outcomes and integrating them into care requires a different kind of framework and culture that's not prevalent in the healthcare system right now. And so our next steps in research are to think about dissemination and implementation through PCORI actually has an option for applying for an award after PCORI is completed to be able to look at methods to improve the uptake of these kinds of interventions in community oncology practices.
That was a fantastic presentation, and thank you so much.
Thanks.
Great insight and certainly a path forward. I'm wondering the degree to which the use of that sort of an assessment or the geriatric assessment, I realize it was, I think, for oncologists, the degree to which it has adaptability or is being adopted by cardiologists in heart failure care, pulmonologists in COPD care, and primary care docs just in their everyday care, where a significant percentage of their patients probably could benefit from their patients and caregivers, and I love the fact that I want to apologize that I didn't mention that. My mother was obviously part of this, and just anecdotally, one of the conversations I had with my mom a few months after my father died was her feeling guilty that she felt relief. You know, I had to say to her, understand, you were carrying a boulder on your back. And that boulder was taken off your back. Even though you didn't ask to have the boulder taken off your back, it was. And of course you feel relief, and that's okay.
Yeah.
And so I wonder also if there's, in addition to use, any caregiver assessments after end of life comes along.
Yeah, so a couple questions in there. Cardiology, I'm not as familiar with pulmonary, but cardiology, like oncology, has a very strong and growing geriatric cardiology group, and the National Cardiology Association, I'm not sure if I'm going to say the name right, has a group, I think, of over 1,500 people interested in geriatrics. So like oncology, they've applied for NIA funding to build infrastructure in this area, so they are starting to integrate geriatric assessment into the care of older adults. And we're starting to see these measures in clinical trials for eligibility and looking at outcomes too, which informs the evidence for how patients and caregivers are treated. In terms of your second question about how people feel after the end of life, I think, yes, we need to support caregivers as long as the patient's living, but that is an important point. And we've done some work with bereavement and found that when we're doing things like geriatric assessment and hospice and palliative care, patients, the adjustment after someone's death actually goes better, depression is less, and people feel more connected to the process than when there's not a conversation, when it's disjointed and complicated. So those things are true.
Question. I think, can you all not hear me? My voice, not loud enough? Dr. Bob Fine, lapsed geriatrician at this point, director of palliative medicine at Baylor Scott and White Health.
Yeah.
So question for you. It may have been up there and I may have missed it because I was taking notes on my phone, but I saw that you had a kind of a checklist. Have you done these things? Mm-hmm. What tool was actually being used, for example, to screen an elder cancer patient for dementia?
So that's a great question.
What tool were you actually using?
Yeah, we didn't have enough time for me to go through the details of the geriatric assessment, but we had a consensus panel using a Delphi process of geriatric oncology experts that helped us pick the screening tools for each of the geriatric domains. And there are options. There's no one tool, as
right,
you
so
know.
Which did you use?
In our study, we used both Blessed and Minicog, because Minicog is easily adaptable as screening tests. MOCA and MMSE are a little burdensome for oncology clinics. And so those are the two we used. If they screened positive on those tests, then that's when they would get the checklist. You need to get better. You need to enlist your geriatrician colleague or a neuropsychologist or a memory clinic to help figure out if the patient truly has dementia versus just screening positive for cognitive impairment.
And then second question, and I'll give the mic back. Who was actually doing the screening?
So that's another great question. So the screening really can be done by almost anyone in the practice, and this is an implementation issue. Doctors think that they have to do the whole thing, and they don't. So we trained the staff members in the practices to do it. So the technicians did it, research coordinators did it, and sometimes nurses, but even many times it was the technicians and the coordinators and not the nurses. The summary was built by the coordinator and handed to the doctor. The doctor didn't do any of the tests themselves.
One more question. Built into the EMR at that
No,
particular practice
that's a
or
great
not?
question. So that's part of our implementation work.
Okay.
So we're trying to do them on iPads and build it into Epic, but we're not quite there yet.
Good afternoon, everyone. And I'm glad to be here and to share some findings and that we have learned from patients and caregivers through Project Achieve. This is a long name, and we tried to come up a good and name for the project, but turned out nobody really remember and what the project is. Everybody just call it Project Achieve. So because the project is funded by PCORI, I have to put the funding acknowledgement and the disclaimer here. So this is, and everybody sees this. A little bit of background about the Project Achieve. I think even though multiple federal, regional, or the local initiatives, there are still a lack of coordination across care setting. And patients really suffer from the poor care transitions. From the research field perspective, we did not know what mattered the most to the patient and their family caregivers. And we also did not know what the combination of the strategies or the interventions will have the best effective to the different patient population. And another thing I think, and the previous speaker mentioned that the dissemination and the implementation is always a topic in the real practice. So the dissemination and the implementation actually is also underdeveloped in the care transition field. So funded by PCORI, actually Project Achieve brings and the national recognized leaders, but most importantly, in partnership with patient and the caregiver to evaluate the effectiveness of the current care transition effort. This multi-site study aims to develop the recommendation on the best practices in improving transitional care and the patient experience and outcome. So now we are going to talk about what the patient and the family caregiver have told us. So this is only one component under Project Achieve. So Project Achieve actually is a 4.5-year study. And this part actually was done back in 2015 and 2016. So what we have done, and actually this part of the study included 138 patients and 110 caregivers from 6 health networks across the U.S., including the Southern California, Colorado, Kentucky, Louisiana, Massachusetts, and Pennsylvania. We conducted 34 focus groups and 80 key informed interviews. All these interview sessions were recorded and transcribed. And then for the analysis, we applied the grounded theory and also the constant comparative analysis. So we got all this done. We have over 2,000-page transcriptions. So what did we learn? What mattered the most? Actually, we learned the patient and their family caregiver can have successful transitions when they feel cared for and cared about, when there is a clear accountability on the part of health system, and when they feel prepared and capable. So those 3 things, actually, even though over 200 patients and caregivers and from 6 different states, we selected the patient, and I didn't include the slides, and we purposely selected the patient with different characters. For example, the low health literacy and the low income, the dual Medicare, Medicaid eligibility, and the multiple and the chronic condition. Even though we have a different sub-patient populations, they all told us the same thing. Those 3 things, that's what they want, and when they leave the hospital. So talk a little bit on detail. Feel cared and feel cared for and cared about. So patient and caregiver, they want their healthcare provider to care about them, because actually it provides the confidence. They know they are taking care of them physically and mentally. So I included I selected one code from each patient and the caregiver, just to give you some idea regarding what they told us during those interviews. I think as one patient mentioned, and they gave me a hug, they wished me luck, and they really sounded sincere. And I was not just a number, a patient in the room. I'm a real person. They treated me as a real person. And so that really made a difference for me. On the other side, and I think if the patient asked a question, and the patient was treated rudely, and that will make them feel humiliated. And that in turn actually, and the patient will shut down and much less engaged in their care. So when people much less engaged and they feel incapable, and they will less likely to adhere to the care plan, and so that can lead to a poor outcome. So next thing is about clear accountability. So basically, they want a clear understanding about who is responsible for the different aspects of their care, and who to contact when they have any problems or questions. So I really like this code and this caregiver and just described the feeling and to us. It's like being thrown out in the middle of a lake, and you are frantically searching for someone on the other side of the lake to help you. So that's the real feeling and about the caregiver and when they take care about their loved ones. So last is about feel prepared and capable. So, for the patients and the family caregiver, and they want providers to tell them what to expect when they leave the hospital, and they can be given the tools to care for themselves. They want to be prepared for the potential issues, and they want to know what to do if those issues occur. So I included actually the positive and experience on these slides. And actually during our interview, there are a lot of undesired experience and mentioned. So I wanted to give the positive part, so I selected the positive and the quotation from the patient and the family caregivers. So this is what the patient and the family caregiver told us. And that's the desired outcome they want. But as a provider, as a healthcare provider, what can we do? I think this is what we ask the patient. And those are the processes of care viewed by the patient and the caregiver as related to their desired outcome. Provide uninterrupted care, provide actionable information, using caring language, anticipate needs, and engage in collaborative planning. So give a little bit on the detail. I apologize for the slides. I use Mac, so there may be some compatible issue about the slides from Mac to PC. So talking about the provide and actionable information and about diagnosis and the treatment. So patient will feel capable when the information is tailored and make understandable and accompanied by some skill training and with conformed comprehension. So that actually is about the teach back. So the teach back is not just knowledge transfer, actually a lot of time how to teach patient use the equipment and use the supply and make sure they can demonstrate they will be able to use it once they get back home. And then the second about the collaborative discharge and the planning. So when you start include the patient and the family member in the discharge planning, and you are going to have this true shared decision-making process. And then they feel they are part of it. And then they will better understand the decision. And then they feel capable, and then they will better follow the care plan because they are part of it. And then if they have a question, they will be able to have opportunity and to get answer, to get clarification. The third one, using the caring language and gesture and the communication with passion. So this actually is about the trust, is about carrying a patient as a person. So quite often, I think the patient and the family member, and they do not require a lot. Even like during the rounding at the bedside, and if the physician or the nurses, they sit down at the patient level, at the eye level, and when they start communicating with patient, that simple gesture and can promote the trust, can make patient feel, oh, they really take the time to talk with me, and then they really care about me as a person. Anticipate needs. And so this I actually mentioned a lot during the interview. And the patient and the family member, they mentioned, you know, this is maybe new to me, this is maybe a new diagnosis to me or to my loved one. I have no idea what is going to happen and after we leave the hospital. But you see a lot of patients like me. And so you know what is going to happen and what we need to prepare, what we need to do, and once we get back home. So anticipate the need and tell them and help them to arrange those. So I want to mention medication definitely is the one important item. So however, the transportation is almost as important as medication. That's also another thing we learned from those interviews. And also the caring responsibility. It is not just the provider's responsibility. It is what patient's responsibility, what's the family caregiver's responsibility. All these actually needs to be communicated and before the patient leaves the hospital. Last, provide uninterrupted care. This one actually is not easy. It's easy to say, but it's very difficult to implement because this uninterrupted care is including informational and the relational, talking about the continuity of care. The informational, and actually we have the technology needs to be involved, and we need to really put the patient at the center and rather than the provider. And then for the relational, it's like how we can get patient's primary care and be in the picture almost on the day one when the patient in the hospital. So those kind of like are the key findings from those interviews. And I will stop here and to see if there are any questions.
So I have a question. Of the three main things in your findings, you know, they have different resolution. And some are easier, as you said, to resolve than others. One, I noticed, I think I mentioned before, that I came out of AARP, and my colleague from AARP, Susan Williams, is here. And the Policy Institute at AARP has put out several versions of a report called Home Alone, which basically refers to the fact that people are discharged from hospitals these days and being asked to do tasks that used to be part of the examination of RNs when they were getting their degree. And these are just regular people trying to do these medical tasks with no training, et cetera. And it seems like that's what you are kind of referring to, is people being asked to go home and having no idea, A, what they're supposed to do or how they're supposed to do it. You know, and I know that there is a law that is being promoted by the organization and is passed in a number of states called the CARE Act, which would put a legal requirement that hospitals provide that information. But I think there's a difference between having a requirement and having it actually happen. So what will it take to get people the information they need? I mean, maybe that's beyond the scope of your study, but it is, you know, other than that, it's kind of like, you know, well, we want to implement these things. What do we have to do? What do you think?
That's a great question. I think in these days, and we do reallocate and quite amount of responsibility and to patient themselves and also to the family caregivers. Of course, and there are always a different level of the clinical skill required to a certain tasks. And so, I mean, for some patient and with a little bit more complicated needs and the clinical, medical clinical needs, I think the home health is still in place. And this is sometimes actually, and I would say the hospital and the team, they struggle a little bit. And they see the needs and for the patient to have home services. And a lot of time, actually, the patient doesn't want anybody to visit them. So I do not want any stranger to come to my home. And during the interview, actually, there are some, I talk about those and the three things, and those patient and caregiver, they are all in agreement, actually, and we also identify some disagreement and between the patient and the family caregivers. Like, for example, for this home service, and so quite often the patient wants to be independent, and they do not want to have those services, but the caregiver understand they need that additional help. And so that is kind of like the communication. I think, and as the care team, and it doesn't matter either it is a physician, the nurse, or the case manager, and can help to serve the role and make the patient understand better why they need the service. On the other side, and for the ones, for example, like taking the medication, and or changing the dressing if there is a wound care. And for those type of things, yes, we do need the family, the patient themselves or the family to do it. And then in the hospital, there needs to kind of like have the opportunity for them to really practice, rather than just show them how to do it. Let them do it before they leave. Make sure they can do it before they leave.
Are there checklists to help the provider and the provider team know whether they've covered everything that they ought to? And is there a companion checklist for caregivers and patients to have a sense of what are the things that ought to have been gone over? They exist in the pediatric world, and I presume they exist in the geriatric world. And if they don't, isn't that something that we ought to be working on?
Yeah, I feel like in the medical care, I feel like here we have this and then here we have this and then in the between, and we really need to do a much better job and to learn from those two ends. So talking about the checklist, actually on the provider side, there are multiple checklists. And so through the different program and the project, actually, and each individual hospital, they have their discharge checklist. And however, and I do not think there is a checklist and corresponding checklist provided to the patient and the family member and ask them to check. So of course there is always a checkbox and to say, okay, provide education to the patient and the family. And however, so that is still listed as the provider's checklist rather than the patient. But that's a great idea. Maybe our next research project, and we can test that.
I have one question. Care is so fragmented as patients leave the hospital. They leave with sometimes a discharge summary and meds, and then they go see their primary care doctor and their subspecialists. And then it sounds like you've been interviewing, people in that process. For patients and caregivers, what do you tell them about how to manage that fragmentation? Because if you consider that it's so fragmented for patients, and then you put the caregiver into it too, and you're giving them resources and a guide to try to empower them, what kinds of things do you tell caregivers about managing that fragmentation?
So I think, what we can tell them, actually, this is the part is about and what the provider can help with this continuity of care and what the patient and the family caregiver and they can take action. I think from the provider perspective, and we need to identify the key information and for the patient and family caregiver before they leave hospital. And because, the discharge summary is pages. Nobody can really remember them. And it needs to be the key information. If the hospital help the patient to discharge and the primary care provider and the follow-up visit, and then anticipate what is going to happen at those visits, what is the information and the patient and the family caregiver needs to tell the primary care provider. So identify those key information and generate a tailored summary, kind of like a little bit like a personal health record, and for them, so they can take with them. And during their the visit and to either the primary care or the specialty. So that's one thing. I think is more from the provider, from hospital perspective, and from the patient and the caregiver perspective. If no one tell you that, and then you take initiative, you ask. And then you ask, okay, what am I need to do? What do I need to do? What's the key information I need to remember? If I take my mom, take my dad, and to see her cardiologist, and then to see the rheumatologist and whatever. So what's the key information I need to tell those doctors? So take the initiative. It's really speak for yourself and speak for your loved ones. And I'm talking about a little bit of my personal experience. So I became a caregiver this year. And I never feel those three things identified through the interview so true until I became a caregiver. And so, I'm lucky that I feel cared about and cared for, I experienced it. But clear accountability and feel prepared and capable, I'm being honest, I was lost. And so I had so many questions, and I didn't know. And once my sister discharged after, from the hospital, and who is going to schedule her next chemotherapy, and what we need to do, and if anything happened during the previous the chemo and the next chemo, should we go back to this specialty hospital or should we go to see her primary care doctor? After personally experience, and then I feel like those three things are so true, and they are not easy to implement, but we got to start something.
Thank you.
Oh, well, I too want to thank Cheryl and her terrific team at CTAC for putting this together, and Eduardo and the terrific folks at AHA for co-hosting this. You guys are doing something really, really important. I am so glad to be here. Well, actually, these days, anything that gets me out of Washington, D.C. is a breath of fresh air, so I'd be happy to be here anyway. But I'm actually particularly thrilled to be here because to hear so many healthcare practitioners and academics talking so intensely about family caregivers really is music to my ears. I think if you think about this, even just a few years ago, you wouldn't have this conversation. We were not paying that much attention to family caregivers, but certainly in the more recent years, we have figured out, that family caregivers matter. It's interesting to hear some of our professional friends up here becoming caregivers. I too am a caregiver for my mother who had a stroke 8 years ago, really from the stress of the caregiver role of being the caregiver for my dad. So I'm actually curious, how many of us here, and those of you who are watching online too, it's worth thinking about, are a family caregiver or have been in a family caregiver situation. Not unusual to see this many. In fact, 2 out of 5 adults throughout the United States now identify as a family caregiver. Well, family caregivers matter because they are doing some pretty sophisticated stuff. Our surveys at Caregiver Action Network, which is the National Family Caregivers Association, shows that up to 70% of the time, it is not the patient themselves who manage the medications. Up to 70% of the time, it's the family caregiver who manages the medications for them. And certainly the more serious condition it is, the more likely the family caregiver is going to be doing it. Cheryl mentioned the numbers about family caregivers doing pretty sophisticated medical tasks in the home that we normally associate with nurses. Indeed, half of those family caregivers across the country are performing those pretty significant tasks. It's not just though that family caregivers matter because they're there and they're doing this stuff. They also need to be better prepared and trained. And why? AARP has a particularly wonderful number. I'm glad they're here. It's just so compelling when you think about it. Right now, if you think of people over 80, there is one of us of caregiving age, like everybody here, for every three people over 80. By the year 2050, that ratio changes so dramatically that there's only one of us of caregiving age for 7 elderly people over the age of 80. So not only doing pretty important things, but we're going to be pretty stretched thin doing this, and that's why we have to be better prepared and better trained. Well, we knew going into this that our friends at PCORI, Patient-Centered Outcome Research Institute, which supported the 2 wonderful studies that you heard about, we knew from our many, many years of dealing with PCORI that there was going to be a lot of very important stuff coming out of this. But what we really wanted to know or figure out is, would real people be able to use the valuable insights that are coming from these researchers? It's one thing if you just, give it to the healthcare practitioners and whatever, and that certainly helps us get to patient-centered care in America. But you can't get to patient-centered care in America just driving it from the healthcare practitioner standpoint. If you are, I will posit you're doomed to failure. That patient and family engagement has to be halfway in there too to get it. And so we just wanted to know if family caregivers were going to be able to digest some of this and use it. So that's what we started off to do. We got into this program, again, PCORI funded, with some lunch and learn programs going across the country. And what we wanted to do is help patients and families, a lot of times the family caregiver would bring the loved one, the patient with them, to figure out how to articulate their personal health goals. Now, that sounds very obvious, and yet it is very uncommon right now in the system. I remember when my mother had a stroke 8 years ago. The very next day in the hospital, the doctor came to her hospital bed and asked my mother pretty point blank, "What's your goal? Now you've had a stroke. Mrs. Shaw, what's your goal?" And my mother didn't really pause very long, and I thought, gosh, what a hard question. But she didn't pause. She took about half a second. She goes, "Well, I have to have a full recovery. I'm the caregiver for my husband, and there's no choice. So I just have to full recover from this so I can get home and do that." And the doctor said, "Well, that's a pretty clear goal. And because your goal is clear, I think you're probably pretty good on your way to getting that." That's a wonderful example of how it should happen, but how it almost never happens, right? Far too often, I can say this in a hospital, I hope this isn't offending anyone, that we really don't ask patients and the families what their goals are, and they're not necessarily prepared to articulate them if they are. And ultimately, we wanted to figure out if family caregivers and their patients, how they could work with the doctors to better identify those treatment options based on their goals, that would help them, get there. A reason for that, and Jing said it so clearly and so well from Project Achieve, you heard it too. Because if the patient and the family is bought into the treatment plan that they are given by the hospital or by the doctor, the chances of success are just so much greater. That's pretty sophisticated stuff. So we went in there wanting to do these lunch and learn sessions with family caregivers because we wanted to teach them about comparative effectiveness research and shared decision-making. Well, that's great. Try talking to real people. Just go home this evening and try to do this. Talk about comparative effectiveness research around the dinner table or with somebody a seat in the bar or something like that. Well, we figured out how to do it. We developed a curriculum. And the fact is, we actually got somewhere. So we did this with 800 family caregivers. And I'm just going to give you some of the details here, but then tell you in a sense what we really actually did. And we figured out that it worked. We did pre and post evaluation surveys in every session of every participant. And I'm just pulling out 3 of the 10 questions here to show you what happened. That we were able actually to move the needle quite significantly. That at the end of these lunch and learn sessions, family caregivers, self-reported, would say they really did know what patient-centered goals were and how to, get to them. They actually, and this is just fascinating, I mean, the actual words, I understand why comparative effectiveness research is important and why it matters to me. So on a scale of 10, it averaged 9.1 at the end of these sessions. I know what shared decision-making is and why it is important. So you think about that. It was really a bit of a surprise that you could come out of an end of a training session, and even with terms as heavy and as freighted as comparative effectiveness research, by the end of it, 60, 80, 100 real live people from the community sitting in chairs like this would say at the end, yeah, I get it. I get comparative effectiveness research, and I know how to use it. This is just an interesting table of the actual 10 questions. We didn't put them all here. I just pulled out the 3. You see, we did have to refine a little bit as we went along, both questions and the curriculum from the very, very early stages, but we did. And in fact, on all the measures, it ended up moving the needle after we got to final refinement of it. I wish I could say we were just smart enough to know going into it what it should be, but no, that wasn't the case. We were only about 80% right, but we kind of figured it out. But having said that success, we also figured out that this really happened no matter where we were, whether it was a rural area or a big city. We purposely chose a lot of different geographical regions and with a lot of diversity in terms of population and culture within the participants. So some pretty small towns like Fort Wayne and Little Rock and Albany. Yeah, try flying into Albany. That's not the easiest thing. But it didn't vary very much from, Los Angeles. We did twice, New York, Detroit, Chicago. Having said that, what did we actually do? Well, we took a 4-hour session. So a 4-hour training session with 60, 80, or 100 family caregivers at once. I will confess that going into this, I thought, 4 hours. How are we ever going to get people, to be here for 4 hours? And I thought that was going to be the Achilles heel of this entire project. Boy, was I wrong. And when I'm wrong, I'm wrong. It is amazing how fast that 4 hours go and how those participants did not want to leave the room. Family caregivers really want to talk. They want to get into this stuff. They want to learn. And how many of them would say, oh, can you come back next Saturday? So I was just completely wrong about 4 hours being too long. But the 4-hour workshop was divided into 4 one-hour modules. First of all, tools, kind of basic tools of caregiving, a medication list, patient file, all that very important stuff that a lot of us think is really quite obvious, but still the majority of people by and large do not do. But it's very important from a family caregiver standpoint. Think of people who are, advanced illnesses, chronic conditions, probably have more than one doctor. They're taking any number of medications. Those medications coming from different doctors really ultimately, when you come right down to it, I know this may sound like heresy, but medication reconciliation really happens between the family caregiver and the pharmacist. We would hope that it happens among the doctors, but it really happens between the family caregiver and the pharmacist. So that's why it's so important to have those those very, very basic tools. Then a module on how to figure out patient and family-centered goals so that you actually can, know what they are. Very important to realize, Jean referred to this a little bit, goals and perspective of a patient and a family caregiver are not always congruent. Sometimes they are quite different indeed. They can have very different goals. And when you get into advanced illness and end-of-life care, boy, can they be different. A patient may be ready to go. A family member, family caregiver may not be ready to have them go. You're on very different roller coasters of that emotional journey. The third module actually talking about comparative effectiveness research. So what did we do? We didn't stand up there and lecture to people. So let me tell you about comparative effectiveness research. We didn't think that was going to go very well. So we actually did it in a role-play exercise. What we would do is we would use some therapeutic area. I'm going to talk about lung cancer here for just 1 minute as the example, but we've done it in heart failure, we've done it in stroke, and we can actually use any therapeutic area as a role-play example for comparative effectiveness research. But lung cancer is a very interesting one, certainly if we're talking about advanced illnesses. We just presented this case. We weren't going to get into the medical specifics. Let's say a pretty advanced lung cancer. And, we know that patients and families have lots of ways of getting information, especially if they want to get information, right? You can go online. Everybody goes to WebMD and Googles and gets to be an expert. You actually do ask family and friends, right? Maybe good, maybe bad, but you do it. You're certainly getting some information from the doctor. You're also talking to people who have actually gone through that, right? Somebody with lung cancer. So those were different ways of getting information. But there are also different therapeutic approaches, right? You could have very intense, chemotherapy and whatever at the end. You might choose nothing. There may be a clinical trial. There are any numbers of ways of doing this. We had kind of 5 different therapeutic approaches. And so we'd vet, 4 or 5 of these family caregivers. We'd give them the little thing. You're actually now Siri. You're going to be the internet. Here's what you say on each of those therapeutic options that are available, if you think about it. You're a doctor. Here's what you would say on each of those. Here's what a family and friend might say. Here's what somebody who's gone through it might say, the pros and the cons. And then at the end of this, we would sort of ask everybody, okay, now having done this, now you've really done comparative effectiveness research, you've thought about all this, you're now going to have a conversation with the doctor. What would you have chosen of these 5 therapeutic options? As you can imagine, in the audience, there's always a few who have this one or that one or the other. But every time, of the 4 times we used lung cancer as the therapeutic example for this role-play exercise, the majority, and I would say the vast majority, of the 60, 80, 100 family caregivers in the room, all chose no treatment. That's interesting, right? Again, forget the details and whether we're, what the actual case may look like. But as you can say to family caregivers, if in this situation, for instance, you genuinely wanted no treatment, I can assure you that without articulating your patient and family-centered goals and engaging that conversation with the doctor, that is the least likely outcome that you would get, right? That's not the doctor's job. The doctor's job is to treat you. You're much more likely to get any of these others. So that was the exercise we're trying to do comparative effectiveness research, and then ultimately training them on shared decision-making, how to actually have those fairly difficult conversations with the doctor, the healthcare professional, especially when, frankly, not every doctor, not every hospitalist wants to have that conversation with the family caregiver and what it means in terms of benefits and costs, right? A doctor may say, well, by the way, there happens to be this great new clinical trial, and I think it might really help. And you might think, well, that's phenomenal. That's a terrific benefit. And then you figure out, well, what is the cost of that? Costs aren't always financial. If the clinical trial happens to be, 30 miles away, I'm working full-time, I don't know how we're going to get them there every week. It's a very, very different kind of decision-making process to make. Well, that's what we did, and thankfully it was very successful. And there were a lot of implications here for end-of-life care, for family caregivers to have the tools to be prepared for that. We were quite surprised. A lot of conversations about DNR, do not resuscitate orders. what a healthcare power of attorney is, a financial power of attorney, all those things, and actually waiting too long, once dementia has begun, to have that conversation with the loved one, to actually figure out what those patient and family-centered goals are for end-of-life care. Very difficult conversation to have, but without that conversation, the goals aren't clear. And then the huge benefit of once knowing those goals are being able to let the doctors and the healthcare providers for that loved one know what they're all about. So that, in a nutshell, is what we did for equipping you for success, training family caregivers in shared decision-making. And you can use any of these research studies, but what we found is that family caregivers are extremely hungry for this type of information. They are just crying out for it. Their appetite is great. They know the burden on them is tremendous, and they want any and all the help they can get. So thank you for that.
I have about 5 questions, but I'm sure everybody else does too. So let me start. You have trained 800, I think you said, family caregivers. How many sessions was that, by the way?
We are 14 sessions. We're doing the 15th 2 weeks from now in Cleveland, and actually now it's over 1,000 family caregivers.
So how is this sustainable? How is it replicable?
Well, the good thing about this program, PCORI funding funded the first 6 or 7 of these, really as to see if it works. And in fact, it did work. And so since then, we have been very, very fortunate, because the numbers spoke for themselves, that companies, hospital systems, et cetera, have figured out, oh yeah, we want patients and family caregivers to be trained on this stuff, and actually have asked us as the national nonprofit to host these training sessions for them, really in this place. So we have done those. So actually the last more than half have been sponsored by hospital systems or pharmaceutical companies. They don't have any input into the content, right? Everything we do is determined by the national nonprofit. But actually, the market has worked. Associations have
so
wanted
how
to
many
support.
family caregivers do we probably have in the United States? Who wants to give me? Well, let's just pretend it's a lot.
It's a lot.
You can't be everywhere, and your team can't be everywhere. So is there any kind of a train the trainer, or, do you have any plan to figure out how to, clone your program beyond appealing to individual hospital systems and stuff to bring John and his team in?
Yeah, we certainly do, and that was actually built into the original model. There is a train the trainer component in each and every session. So in addition to the 60, 80, or 100 family caregivers who are participating, there will be a handful up to a dozen trainers who are also present, and they also get an extra hour and a half so that they can actually take the curriculum that was developed by the national nonprofit and use it in subsequent sessions. We have certainly videoed and webinared as well, and we have also figured out how to truncate it. Not everybody wants to have a 4-hour session, so we can do it in 1-hour or 2-hour sessions as well. And then we actually also developed a companion curriculum for especially hospitals, since we're in a hospital, I'll talk about it that way, called Upstream, which is basically to have hospital staff, but everybody, whether it's social workers, discharge planners, doctors, admin folks. Think of an hour-and-a-half grand rounds session that's really targeted on family caregivers. How to engage the family caregiver, what use they are to you, how you want to use them to make sure you're using them. Ultimately, if you don't want to get dinged financially for readmission rates of 30 days down the line, you probably want to involve those family caregivers, because they're the ones who are going to care for that patient once you put them out the door with the right discharge process, because you looked at Jing's Project Achieve results and know what what policies need to be in place.
My colleague and I provide respite services for caregivers, and at the end of the assessment, there is a caregiver assessment that we do. And the last question is, what tools have you left for the caregiver to use? And on your agenda, you mentioned the Caregiving Network. Yep. Is that a tool that they could possibly use to get help?
Yes, absolutely. So Caregiver Action Network has tremendous, a lot of robust online resources for the caregiver at caregiveraction.org. And a huge part of it, I would say a good half or more, is exactly what you talked about, right? This was a little bit about preparing, training the family caregiver for, care with the patient. But remember, as is so important, at least half of it is taking care of yourself, right? My mom's stroke, again, it was from the sheer stress of being in the role of a family caregiver. That stress takes a tremendous toll on the family caregiver's own health. Family caregivers much more likely to have hypertension, to suffer stroke, twice as likely to have diabetes. Depression, huge, right? Family caregivers twice as likely to be depressed as non-caregivers. And actually, very interesting, if you're a wife caring for your husband, 6 times more likely to have depression than a non-caregiving wife. So yes, there are lots of tools that we have for the caregiver, for assessing yourself, taking care of yourself, how to find respite, sort of little gimmicks, tricks that you can do. Because nothing's tougher, really, than figuring out how to take care of yourself, especially when, all those psychosocial emotions come into play. It's interesting, Eduardo mentioned with the guilt. If you want to think about what happens in a family caregiver's mind, isolation, guilt, anger, right? I am downright angry. I'm trapped. I don't want to be in this situation. This is not what I signed up for. Now, I don't want to say that to my loved one, right? But I have to find somewhere to vent that, because if I'm building it up inside and don't have a place to vent it, boy, is that going to take a tremendous impact on my health. So yes, caregiveraction.org for that stuff, so I'm glad you brought that up. Critical.
On the slide where you detailed about the different questions, and certainly all of them except for one, you had an increase.
Yep.
The one that was, I believe, 1A was the only one, or 1B, I think it's A, had a negative. What was that question, and tell me a little bit about how it went back.
Yeah, I'm trying to remember. What happened was, and we figured this out in the very, very, very first session. 1A was it really ended up being a verb tense. So the people really weren't understanding the question as opposed to before and after. And so that's really what happened with it. I'm not sure it's now been almost 3 years, so I'm blanking on the actual wording of the question. Once we saw it, it was like, oh, yeah, duh, of course. But it's amazing what you don't realize when you're putting the question together. Especially since we were patterning it after something that was research validated. Dr. Eric Coleman, has his FRAC questionnaire for family caregivers, and that's where we started with to get these 10 questions. And we had to modify and change and add some and subtract some. But it just goes to show, until you put it out there and test it, you're never going to know what happens, how real people read it, no matter how you do it. Then after that, and that's why 1B since then has actually been pretty much like the others, with a 2, 3, 3.5 point increase. Yes.
So thank you so much. That was a great presentation. I actually went to the Caregivers Network, Caregivers Action Network website, and it's good information there. One thing I didn't hear talked about, which was an issue when my father died and my mother was sort of left trying to figure out what to do. So caregivers need to know, obviously, and want to know what to do while their loved one is alive and they're taking care of them. But when death happens, I'll tell you what, my sister and I became like experts in funeral arrangements, in Social Security benefit transfer, and it just seems to me that in this conversation about helping families prepare for what might be coming, are there those resources available, and how does one begin to offer them in a way that, again, is not suggesting we're trying to accelerate the death of your loved one, but is really about making sure that day one after death, Someone isn't left trying to figure out, oh my God, I don't know the password to the bank account, which are probably things that play out every single day. And the other one is not understanding your Social Security benefits. So there is a death benefit. It ain't nothing compared to the monthly benefit, and the reduction in monthly benefit can be very significant for somebody, and if they're not prepared, it can be kind of a shocker.
Sure, and if you're the executor of the will, what all that entails and how you can get, caught up with the court and don't know what's happening. This is the real problem of being with an audience that's too smart, because Eduardo, I think, actually did point out what right now is a gap. And we have figured that out, too. A lot of people have said this to us in the last year or two. And we're going to go ahead and put that together as a separate thing, so you don't have to go wading through every other of the 2,000 resources to get to it. Because it is hugely important, and right now there isn't anything in one place. None of us is born knowing how to do this, and caregiving is tough, but you're right. Then the person passes, and oh my God, in that first 24 hours, you are completely at sea, not knowing how to handle it. So yeah, we'll do that.
So John, just one more in terms of support, and maybe you can offer just anecdotally how you're managing this, and that is the challenge that sometimes HIPAA presents to caregivers, being able to be actual caregivers. And particularly, it's one thing if people are willing to overlook HIPAA and actually break the law and offer information, because you are breaking the law if you do it. But domestic partners or same-sex married couples, it gets a little tougher, because sometimes there's not the clarity or the understanding that the same rights are afforded to all kinds of people who are married, and or the same rights are not afforded to people who are married.
Right, yeah, HIPAA. In fact, we do have resources in caregiveraction.org, and actually that's not the only website we have. We have others, rarecaregivers.org, helpforcancercaregivers.org, et cetera. And we do have them in there on HIPAA, how to navigate, and really from a family caregiver standpoint, because not only do all those challenges come to bear, but then, I don't want to cast aspersions on anyone, but let's say in the severe mental health world, a lot of times, this just generally happens, the psychiatrist will tell the family member, no, I can't talk to you because of HIPAA. And what they're really doing is hiding behind HIPAA and creating a barrier that does not really exist. So we walk family members through that, what HIPAA means, what it doesn't mean, who's covered, who's not covered, you as a family member are not a covered entity, and that you can always have a conversation, right? There may be some things they can't tell you unless they think the patient is in danger to themselves or others, but you can always be giving them information. And of course, nothing is more important than the observational status of a family caregiver. We're with the loved one 24/7. Our doctors are with them, I don't know, how many total hours a year? 10, 12? What we see in terms of symptoms, side effects, et cetera, is hugely important. So yes, we actually do walk them through that because I think far too often people are afraid because of HIPAA, and I think in too many cases, and I don't really want to cast aspersions on some, but some healthcare professionals will actually hide behind HIPAA and create a barrier that should not exist for the family.
So I will say, I think it's great, the stuff you're doing. And I think it's great that you're going to be going back to the last question, that you're going to be giving in more detail what people can do, the things they have to keep in mind and how to handle them, because I think you're doing some hands-on work there. In the interest of letting 1,000 flowers bloom, I think there's always enough of this. And so I'm going to make a plug for my former employer, AARP, which has some pretty significant publications that are consumer-friendly that are available in a number of languages, and one is called Prepare to Care. It does give some checklists and things like that. I think there's a lot of space there still for people who are going to be teaching people how to do these things, but that is one resource that can be used. And over here.
Yes, hi, thank you. I work for the Coalition for Aging LGBT, and I'm curious with any of the panel here today, any insights that you have about the growing LGBT elder community and any insights into how to better care for their needs. We've been hearing family caregivers. A lot of our older LGBT people don't have family for various reasons. And I know that they can get caregivers from other places, but I'm just curious if you have any insight about that.
Yeah, let me take it on. I'm sure others will have something to say too, but caregiving for LGBT elderly is actually one of the fastest growing areas. You look at how family caregiving has changed over the last few years. If anyone sits around and talks to you about family caregiving and just still says, you know, the 49-year-old woman who's married, she's got children at home, caring for elderly mother-in-law, and she's got a full-time job, and they stop there, stop listening. They don't know what the hell they're talking about. Yeah, that's still true. Absolutely, that woman is still doing it. But the real change in the last few years has been the dramatic increase of men, the dramatic increase of millennials, and the dramatic increase for the need of caregiving for LGBT elderly. So we actually have been going pretty deeply into that, and with organizations like SAGE, which actually take it on directly, and make sure that in each of our sessions that's addressed. It also makes you wonder, you know, you have this conundrum about language. The words are never actually quite right. And family caregiver is one of those that's, again, not quite right, because there are a lot of loved ones who literally aren't family relatives. But if you just say caregivers, then some people are thinking of the hospital staff or the nurse practitioner. It gets really, really tough. It really does. And, you know, we have endless hours-long sessions trying to come up with better words or create new words that are be inclusive about that. But you could not be more right. And so, yes, we do directly address it.
Yeah, one thing I will add, we used to have huge debates about this, and I think at CTAC and previously at AARP, we considered the word family caregiver to be essentially family and friend, or informal caregiver, someone who was not an employee of an organization coming in to take care of the person. Although there's a lot of similarity between the needs of the paid caregivers too, and the interaction between the family caregiver who has to often hire and supervise paid caregivers and coordinate all of that. So there's a lot going on there. I will make one more reference, which is, and I don't know if you can probably get it on YouTube. CTAC has a friend, her name is Cathy Bryant, and she is a nurse, oncology nurse. She's worked in the end-of-life field her whole career. And she was recently diagnosed with stage 4 cancer. And she and her wife have been going through this. They have a college-age son. These are two women who are married. They lived in Washington, D.C. They just moved to Charlottesville. And she said, knowing what I know about this, you know, she's made a decision not to have chemotherapy. She had surgery, but no chemotherapy. And she is rapidly declining, and she expects to die, frankly, before the end of July. And she did a video that if you come to the CTAC Summit, we will be showing it. She did a video for us. She and Kim, her wife, did it. And it's really very moving, but it is interesting when she talks about the challenges of being an LGBT married person, and not, in many ways, people do not choose hospice, or they do not choose that kind of care because they don't think they are going to get the same kind of respect and care as a heterosexual married couple would get. So I would say it's interesting. And you know, after this is all over, we're going to send you an email with a lot of references that you can look up so that you don't have to, you know, with links, nice things like that. Okay?
So I'll just add, with regards to the American Heart Association, we have stood up an Office of Health Equity, and whereas maybe traditionally and in the not too recent past, when we thought about equity, we were thinking about race, ethnicity almost exclusively. We have a much broader sense of what that is, and actually are engaged right now in a deep dive looking at the cardiovascular risk and disease profile of LGBTQ. We already know at a 30,000 foot level there are tremendous disparities that warrant calling out and addressing. And I have no doubt that if we were to look, there are parts of our country where it's more challenging than in other parts of our country, rural versus urban. All of those things are things that we are committed to working with partners like CTAC around this issue to make sure that there's an equity approach and be explicit about it. But then also in all the other work that we're doing, we're trying to be absolutely always asking ourselves, are we considering all the things that we need to consider? I'll add one thing. I do think that we probably all have a responsibility to begin thinking about the idea of cultural competency, if that's the right word, around how one provides care in a compassionate, active listening sort of way to anybody who walks in the door and with anybody who comes with them. So I thank you for asking that question and calling it out. I think it's critically important.
Okay, now we have a little bit of time left, and what I would like to do is offer you folks in the audience first an opportunity, if anybody has a question or a comment, it doesn't even have to have a question mark at the end of it, if you would like to do that. And once anybody in the audience has had their say, I'm going to ask each of our panelists to just speak for a minute as to what are their concluding thoughts, what message they want to leave us with. And so you need to talk now so that they have time to think about what they want to leave us with. Way in the back. And if you could identify yourself and your organization, that would be great.
Sure, I'm Robin Korbar with Catholic Charities. Thank you very much. This has been really informative. I'm working at a senior center here where we have maybe up to 100 people, 60 and plus there, and many of them are caring for each other as friends. So I think that's the other thing I just wanted to kind of put out there along with your question is that there may be a lot of people who are just in a friend situation, or sometimes what we've seen sometimes with our elders is that maybe there's kind of a gray area between two people. Is it is this a friendship? Is it more than a friendship? Where do they start to draw the line if there is no other family helping care for each other? So I think that's something also to be really sensitive to in our comments with families is just, again, where is that line? If maybe somebody doesn't want to be in a relationship, but they're almost, by virtue of just being with this person for 3 or 4 years, taking care of each other, it just gets very gray really quick for them. I really love the questionnaire that you were just talking about and this service. I'm wondering, do you have anything in Dallas as far as a training for a Train the Trainer? Is there anything in this area that's coming up? Because it'd be fantastic to get plugged into that.
Yeah, I gave it to her. Oh, I see. Gotcha. We haven't yet done Dallas. We are actually talking right now with some in the Dallas area who might want to host it. We did do San Antonio, which was hugely successful. So yeah, we are actually trying to do a session in Dallas, in the immediate future, sometime in the near future.
What does it cost?
Well, the cost can vary. So if it's a rich organization that's going to sponsor it, it's $40,000 to do everything. But if it's not a rich organization that's going to sponsor, we're a lean, mean nonprofit, so we can always do it at something or other. Because ultimately, our mission is to help as many family caregivers as possible, and so that's what we're trying to do. But if you were Johnson & Johnson, I would charge you $40,000.
Susan?
Hi, I'm Susan Williams with AARP Texas. I wanted just to bring up the issue, not so much as a question, but if anybody has insight on what kind of outreach is being done with employers when it comes to family caregivers. AARP is very progressive in the benefits we have, but I found out this year when I became a family caregiver that I had 40 hours of caregiving leave. So I did not have to take vacation, sick time, personal days, but I was able to take care of my person and go with him to all the stuff that he needed to go to. That's a gift, but something that I really think is something that there needs to be more people that have that, because when I talk to people, they're just astounded that I have that.
So let me jump in there if I could. And, I've talked to a lot of the AARP folks in Washington about this on the workforce side. 60% of family caregivers are working. Most are working full-time, right? It's not elderly grandmother caring for elderly grandfather when he's sick and elderly grandfather caring for elderly grandmother when she's sick. Yeah, that happens. But most of us are working full-time. And so there has to be some help to support those family caregivers. At any given time, 1 out of 5 of those workers on the job are going to be doing caregiving that day. So what we did from the national nonprofit CAN is we actually created a program called ACE, Assisting Caregiving Employees, which is an off-the-shelf program, website of robust resources that a company could simply take, brand if they want or whatever, but from the White Hat nonprofit, that puts all these supports in place that we know from 27 years of doing this that you as the employer need, as the employee need. I want to go with something about the 40 hours, which is phenomenal, and what a great leap forward, and oh my God, how sad that we're talking about this as a great leap forward, and how inadequate that is, right? If the only thing we do is give a bunch of extra hours to the employee to be able to take off, all we've done is chase the tail of the problem, right? What we want to do is put supports in place for that employee beforehand, so when, they're tracking their depression, they're tracking their health issues, they're not having a stroke, can reduce their absenteeism, et cetera. So just this leave at the end, though a huge step forward, but my God, is that inadequate. We have to have supports before to not chase the tail of the problem.
So let me make a commitment, and the AHA team that's here will hold me accountable. We are the convener of something called the CEO Roundtable. It's about 50 Fortune, probably 200 companies that have come together to think about what are the things that employers can and should be doing. And despite the fact that this is an AHA convened roundtable, the thing that we are doing a fair amount of work around right now is mental health in the workplace. And it seems to me that this conversation is an offshoot or a part of that very same conversation. And what I'm committed to doing is, if indeed there's a resource that already exists, it's to try to maybe use what happened here today as a way to just sort of bring this topic to the CEO Roundtable, along with just here is at least one place where there's a set of resources, and see if that sparks some conversation. Among the employers are Kaiser Permanente, Humana, U.S. Food, Hearst. There's just any number of organizations. They serve more than 100 million Americans every single day, and they're trying to be thought leaders in how to improve the health and well-being of their employees and the folks that depend on those employees in one way or other. So thank you for your question. It's a prompt to kind of move a conversation along on the AHA side.
I'm Robin Corbar again with Catholic Charities. This is not necessarily something that I'm dealing with at work, but something that's really become apparent in my community is the huge need for mental health services along all of these lines too. When we're looking at young kids who are between 18 and 22 who are starting to get schizophrenia, bipolar disorder, things like that, I'm seeing an increasing number of young kids on the streets here in Dallas that are dealing with those diagnoses, and there really isn't any kind of consolidated program to help those with mental health issues. Those continue for a lifelong span and present a lot of challenges. You talk about time off of work for people who are in that sandwich generation, dealing with maybe an older person who's on the end of the life spectrum, but also a younger person who may have significant mental health issues. It'd be wonderful to see these kinds of resources provided for those families too.
Thank you for bringing that up. I think that implied in your comments also is there is a tremendous caregiver burden to families of families with family members with mental health, serious mental health issues, and also not so serious mental health issues.
So, yes, we have time for a couple more, and before you talk, I want to say I have to apologize for our friend John Shaw. He had a flight to go to. He wasn't just trying to get away from making any kind of final commitments.
I thought he was Superman.
We're going to find him.
There's criminals to take care
Are you working with people who have long-term health insurance? And if so, what can you do to prepare us who have signed up for that but need training, need help, especially if a family member is utilized instead of going to an organization to get someone in? Do you?
That's a great question. That's a fabulous question. I think the guy who left might have been the one who would have been best able to answer that question, unless anyone else can answer.
I just have experience with my own patients, and it's not set up right. Most long-term care insurances are not set up in a way that's caregiver friendly, or allows a caregiver to take the employment of caring for the patient. There's still a lot of difficulties with that. Even if you've done everything you're supposed to do and you get the thing the proof, the paperwork, it's complicated. So that there is I think for Mr. Shaw here, another avenue of how to teach people to even sign up for long-term care. What are you looking for? What are your benefits when you sign up?
Yeah.
I think that's a whole nother area of need.
I can tell you that if you don't already have long-term care insurance, you're not going to be able to buy it because the companies are going belly up because of the way it's funded. People are living longer and making a lot of claims on it, and insurance exists when you spread a risk over a large number of people.
I've had it for over 20 years.
Yeah,
myself
if
and
you
my
have it, I mean, I think that if you have it, it's great. Sometimes they will, as the policies had evolved before they kind of went bust, they were starting to provide benefits where you could get 50% of what you would pay for a professional home care aide could be paid for a family member if that family member was taking care of you. There are some policies, but you really need to look at what the policy says and what it will do. And, like every contract, it's determined by the words of the contract. So it's not going to be an answer for a lot of people. For those who have it, it might provide some assistance. Anybody else have anything they want to say to us to enlighten us or provoke us? Okay, then I am going to go to our esteemed panel, and I'm going to ask, well, Dr. Sanchez, do you want to say something again?
I'll just say thank you very much for being here. Thank you all for being here. Thank you for expressing, by being here, your interest in this issue. I want to thank the presenters who did a fabulous job of laying the groundwork on the science that is beginning to evolve and around which we have much more to do. And thankfully, PCORI and others are helping to do that. I want to thank CTAC and you for the partnership to co-host this, and look forward to continued discussion, progress, and reports back from some of y'all about things that y'all are doing to address this really important issue. So just thank you one more time.
Dr. Lee?
Definitely, I also want to thank you for this great opportunity. And so I think what I presented today, it is, as I always say, it is easy to say, but it is very difficult to implement. And a lot of time, actually, it is not just on provider level, it is more the health system level. Since the AHA has this CEO roundtable, I do think actually a lot of things need to happen at the system level. I'm a big believer regarding the structure, process, and outcome. And so if we do not have the structure in place, and if we only rely on each individual provider, we won't be able to go far. It needs to be at the system level. Actually, I think now, and we are in the time, and with this and the value-based care and the bigger environment and all the alternative payment model, and I do hope at the system level and the administrator, they can see the value and to look into this and then to see how they can start with and those research fundings and to provide the true value care.
I agree with both speakers before me. I agree it's a healthcare system issue at this point. I mean, I think we're learning more and more that caregivers are partners, they're part of the team, and that the health of the patient and the caregiver are interrelated. And if you neglect one, you neglect the other. And so if our goals in the healthcare system are to improve outcomes and make patients better, we have to pay attention to the caregiver and partner with a caregiver too. You know, it has been more recent. I think I've been been practicing for the last 15 years, and when I was in training, we never talked about the caregiver, honestly. I was in fellowship. It was never part, the caregiver would be sitting there, but we never turned to the caregiver and included them in a shared decision-making model, or there was no real programs for that. We made sure they were okay, but there was no discussion around it, so that has definitely progressed. But I also agree that we have to start with action items, and we have to prove to healthcare systems and insurers that interventions for caregivers and paying for those interventions and paying for help when it's needed and paying for mental health care really ultimately helps the healthcare system and their outcomes, because it keeps people out of the hospital, it makes people better, et cetera. So that's where we need to get to. We need to be armed with that kind of data so we can convince policymakers and healthcare systems that focusing on the caregiver is important and will help them.
Thank you. Yeah, I think it's pretty clear that while our goal is not to save costs, often when you are talking to policymakers, that's the argument that will get them. And we know from our experience that actually giving people the care that they want and giving them the information and empowering them to make decisions and empowering their caregivers, people do end up probably spending less money because they don't go to the hospital as much. They don't end up in the ER as much, even whether they're admitted or not. They choose less intense therapies because they think about their goals and they think about what are their goals. And if they do want the intense therapies, they can get them because we are, that's probably going to be the default anyway. So I would like to thank everybody. We are going to send you some information. We are thrilled that you came. We are thrilled for our televised audience. And we hope to see you at the CTAC Summit, which is going to be in Minneapolis, October 9th to 11th. We have a number of caregiver track sessions there. And I'm going to try to rope some of the people here into working with us on those. So now I would like to thank our panelists, but before I do that, because I know the minute I do that, everybody is going to get up. We do have a little reception area outside, and we have some refreshments, and we hope that people will stick around and talk to each other a little bit after we finish. So now, can we thank our panelists? And if you are listening, I would love to thank the Scottish Rite Hospital for giving us this beautiful, wonderful, technologically superior venue to have our session in. So thank you, folks. All righty, let's go.
It's all about figuring it out.
No, I know it is, and I've worked with Debbie a little bit.
Debbie